Welcome to the deep dive. Today we're getting into some really heavy stuff. We're looking at advanced orthopedic reconstruction. This isn't just about fixing simple fractures.
No, definitely not. We're talking about rebuilding things when they've gone seriously wrong. Think fail healing, severe trauma, malunions, non-unions. We're digging into the complex procedures, drawing a lot from Campbell's Operative Orthopaedics, the standard.
Right, and we're approaching this like an attending walking a resident through a really tough case in the OR, looking at the nitty-gritty details, why certain complex steps are needed when the first plan didn't work out.
Exactly. What do you do when you're left with a bone that's healed crooked or hasn't healed at all? Or, worse.
Our mission here is to really break down the technical skill involved in the decision-making process, which can be pretty complex, and the biological compromises you sometimes have to make.
It's true. This isn't straightforward. It's like, imagine trying to debug some ancient, messy computer code.
Yeah.
Except this code isn't just buggy. It's actively fighting your fix. And you have to rebuild the whole thing while the system is still, running. It's biological failure layered on structural problems.
That's a great analogy. And the stakes are incredibly high. When a bone heals wrong, a malunion, or just refuses to heal, a non-union, you're shifting gears completely.
Absolutely. You're out of acute trauma mode and into salvage surgery. It requires this weird mix of microscopic precision for some things, like nerves and vessels, but you're dealing with huge mechanical forces at the same time.
Function, pain, alignment, blood supply, nerve function. Got to juggle it all.
Yep. So let's dive in. Where should we start? Maybe with fixing alignment that went sideways, malunions.
Okay, malunion. So the fracture healed, but it healed. Wrong. Bad angle, twisted, maybe shorter than it should be. It's not just about looks, is it?
Oh, definitely not. It throws off the biomechanics of everything around it, causes stress on adjacent joints. It can be totally disabling.
And the source material, Campbell's, points to some areas that are particularly tricky.
Yeah. I mean, you see tough malunions in long bones, humerus, forearm, rotation issues there. But the foot and ankle, that's often where the really disabling problems show up because all those little joints have to work together perfectly.
Right.
And the talus. We got to talk about the talus right away. A malunion there is almost guaranteed to cause problems. Think about it. That one bone connects to the tibia for the ankle joint, the calcaneus below it for the subtalar joint, and the navicular in front for the talonavicular joint.
So if the talus is off, the whole system is compromised.
The whole rear foot engine, yeah.
Wrecked.
And there's that really concerning analogy the book uses for a malunited talar neck fracture.
Ah, yes. It explicitly compares it to an intracapsular fracture of the femoral neck.
Which immediately screams high risk.
Exactly. It's a big warning flag. It means high risk of arthritis, chronic pain, and the big one, a vascular necrosis, AVN. The blood supply to the talar head or body can get choked off. It's already a bit precarious anatomically, and the injury plus the bad healing position can just kill the bone. So when you go in to fix it, you're walking a tightrope. You need to fix the alignment, but you absolutely cannot compromise what little blood supply might be left.
That's the challenge. How do you correct it without causing the AVN you're trying to avoid?
What's the technique?
It involves a very precise osteotomy, a cut in the bone right at the talar or neck, at the exact peak of the deformity. Then, to hold that correction, you need a structural bone graft.
Okay.
The classic maneuver described is using a rhomboid-shaped piece of the patient's own iliac crest bone. Tricortical, meaning it has 3 layers of hard cortex.
Like a custom-made wedge.
Exactly. It props the correction open, gives immediate stability because it's strong, and hopefully allows things to heal in the right position. But the dissection, it has to be incredibly meticulous. You cannot strip the soft tissues that carry those tiny blood vessels feeding the talus.
Unslip and?
And you've potentially turned a painful, deformed foot into one with dead bone. Unsalvageable sometimes. Very high stakes.
Okay, so if the talus is the high-risk zone, what about the calcaneus? The heel bone? That seems more like a structural engineering puzzle after a bad fracture.
It is. Calcaneal malunions, often from falls, they typically result in the heel becoming wide, losing height, and tilting into varus inwards. Super painful, hard to walk on.
And the go-to fix for the really bad ones.
For those complex deformities, the gold standard procedure is something called a subtalar distraction realignment arthrodesis. It's a mouthful.
It sounds like it. Break that down.
You're basically doing a controlled demolition and rebuild. Goal 1, fix the alignment. Goal 2, fuse the subtalar joint in that corrected position so it doesn't move and cause pain anymore. If you look in Campbell's figure 58.3, shows the steps really well.
Okay, so walk us through the mechanics of that. It sounds way beyond just putting in a plate.
Oh, it is. Requires careful planning. First, you got to find the subtalar joint, which can be tough with all the scar tissue and deformity. Then you cut a very specific slot, a mortise, into both the calcaneus and the talus.
Dimensions are key here.
Yeah, they specify about 1.3 centimeters wide and 0.6 centimeters deep, running forwards. That's not random. It's the space needed to wedge in the graft and lever the heel back into position, restoring height and alignment.
And they mentioned using a femoral distractor. How does that work?
Right, so you put sturdy pins into the tibia above and the calcaneus below, usually on the medial side, the inside. Then you hook up this femoral distractor. It's like a mini external fixator frame with a screw mechanism.
To pull things apart.
Exactly. You crank it open and it generates a huge controlled pulling force. This does two things. Helps stretch out the tight, soft tissues, and crucially, because those pins are medial, as you distract, you're actively correcting that hindfoot varus. You're literally prying the heel outwards back towards neutral.
That's clever. High-tech leverage.
It is. Once you've distracted it open and got the alignment right, you jam in that wedge bone graft, usually tricortical iliac crest again, into the mortise you made. Then lock it all down with screws or a plate.
Seems very focused, combining external distraction with internal fixation and grafting. But what about the soft tissues on the outside? That widened heel must cause problems there too.
Absolutely critical point. The lateral wall of the calcaneus often blows outwards, creating this bony prominence and exostosis. It's not just bone, it physically squishes the peroneal tendons and their sheath against the fibula. Chronic pain, tendinitis.
So you have to deal with that too.
You must. It's called a lateral wall decompression. Technique 58.6 describes it. You basically go in, lift the tissues off the bone, and shave down that bulge to make space, ensuring those tendons can glide freely again. If you skip that, the patient just trades one type of pain for another.
Makes sense. Okay, let's move up the body. Proximal humerus malunions, shoulder problems. What defines the failure there?
Functional devastation, really. The tuberosities where the rotator cuff muscles attach get pulled out of place. The joint surface itself might be uneven. The whole bone might be angled wrong. Result, awful range of motion, weakness, pain.
So how do you decide whether to try and fix the bone itself, an osteotomy, versus just replacing the joint, arthroplasty?
The main deciding factor is the health of the articular cartilage, the joint surface, and the status of the rotator cuff. If the joint surface is severely damaged, if there's a lot of AVN, or if the rotator cuff is torn beyond repair or just not working, then arthroplasty is usually the way to go.
Hemiarthroplasty or total shoulder?
Could be either. Hemi just replaces the ball, total replaces ball and socket. Depends on the state of the socket, the glenoid.
And what about those really tough cases with massive rotator cuff failure?
That's where the reverse total shoulder arthroplasty, the RTSA, really shines. It's designed specifically for that scenario. It flips the ball and socket geometry, so the powerful deltoid muscle can lift the arm, bypassing the need for a functioning rotator cuff. It's a fantastic salvage option for these complex malunions with cuff deficiency.
But the outcomes for arthroplasty after a malunion, they're not quite as good as when you do it for simple arthritis or an acute fracture, are they?
That's the tough reality. Pain relief is usually pretty good. Maybe 75–85% get significant relief. But function, getting motion and strength back, it's often less predictable, less favorable. You're dealing with muscles that have been scarred, shortened, or weak for a long time. Stiffness is a major battle.
And trying to fix the bone itself, the osteotomy, the book warns specifically about trying that on the greater tuberosity.
Yes, a strong warning. Trying to cut and reposition a badly healed greater tuberosity fragment, it often ends poorly.
Why? Blood supply again.
Devascularization risk, exactly. The dissection needed to free up that fragment often destroys its blood supply. Mansett and Boileau both published series showing pretty unsatisfactory results, non-union of the fragment, migration, persistent weakness. Boileau's series, I think, none of the patients got above 90 degrees of active elevation.
Ouch.
Yeah. So the consensus is if that tuberosity is way out of place and the joint surface is bad, trying to salvage it with an osteotomy is probably a bad bet. Arthroplasty is likely the better, more predictable option.
All right, let's shift from bones healing crooked to bones that just don't heal. Non-unions. First, definitions. What's the difference between delayed union and a true non-union?
Good question. Delayed union is sort of an arbitrary waiting period, maybe 3 to 6 months, where things aren't progressing as expected radiographically. A non-union, though, that's definitive failure. Clinically, the patient still has pain, maybe motion at the fracture site. Radiographically, there's no sign of bridging callus, maybe even sclerosis or resorption at the bone ends. The bone has biologically stalled. It's given up trying to heal.
And the impact on the patient.
Mm-hmm.
It's way more than just a physical problem, right? The source had some really stark data on this.
Yeah, this is crucial to understand. Figure 59.1, it shows patient-reported physical health scores using the SF-12 survey, and patients with a femoral non-union. Their physical health scores are significantly worse than patients dealing with really serious medical conditions.
Worse than what?
Worse than patients with congestive heart failure, worse than type 2 diabetes, worse than end-stage hip arthritis needing replacement.
Wow, that's profound. A single broken bone not healing hits harder physically than major systemic diseases.
Think about YU. It's chronic. It's often unstable, so every movement hurts. It completely stops rehab dead in its tracks. They can't work, can't rely on the limb, constantly feel like their body failed them. Unlike CHF, where there's a known path, non-union feels like this painful, indefinite limbo. It puts their life on pause.
That completely reframes the importance of fixing it. It's not just bone repair, it's life restoration.
Exactly. Which is why our treatment has to be aggressive and based on understanding why it failed. And that usually comes down to biology versus mechanics.
The hypertrophic versus atrophic types.
Right. Hypertrophic non-union, you see that big fluffy callus on the x-ray. Looks like an elephant's foot or a horse's hoof. The bone has the biological juice to heal. It's trying. The problem is mechanical. It's not stable enough.
So the treatment is?
Stability. Rigid fixation. Usually that's all it needs. Maybe compression across the site. No need for bone graft typically. The biology is already there.
And the opposite end? Atrophic non-union.
That's the scary one. On x-ray, the bone ends look tapered. Maybe pencil thin, sclerotic, dead looking. There's no callus. The failure here is biological. It lacks the cells, the blood supply, the signals to heal.
So treatment has to address that biology?
Absolutely. You need rigid fixation, yes, but that's not enough. You must stimulate the biology. That means aggressive decortication, roughing up the bone ends to get bleeding bone, and you must add bone graft to bring in fresh osteogenic cells and growth factors. It's a full court press on the biology.
Okay, let's talk fixation. Nails versus plates. Intramedullary nailing is kind of the workhorse for long bones, right?
For the femur and tibia, yes, especially for closed fractures initially. For non-union in those bones, particularly hypertrophic ones, a technique called exchange nailing is often very effective.
Maybe.
You take out the old nail, ream the canal larger, and put in a bigger, stiffer nail. It increases stability significantly. Works well for femur and tibia non-unions that failed mechanically.
But not everywhere.
No. The source specifically cautions against routine exchange nailing for humeral non-unions. Higher risk of vascular injury up there, and it's harder to get truly rigid fixation compared to a plate. For the humerus or forearm or clavicle non-unions, plating is often preferred.
And with plates, there are different strategies.
Yeah, it depends on the gap in the biology. You can use compression plating to squeeze the ends together if there's good contact. Neutralization plating just protects a lag screw fixation. Bridge plating spans a gap where there's bone loss or severe comminution. And then there's wave plating, where you contour the plate off the bone slightly over the non-union site. The idea is to allow some controlled micromotion to stimulate healing while still providing overall stability.
And for the atrophic ones needing graft. Iliac crest has been the standard, but it hurts. What's the modern alternative for getting lots of graft?
The Reamer Irrigator Aspirator, or RIA system, game changer.
How does that work?
It's basically a specialized large-diameter reamer that you use inside the canal of a long bone, usually the femur or tibia. While it reams, it simultaneously irrigates and sucks out all the bone debris, which is packed with stem cells and growth factors. You can harvest a huge amount of high-quality corticocancellous autograft, like 50, 60 cc's, through a relatively small incision.
Way better than taking a massive chunk out of the hip.
Much less donor site pain, lower complication risk, and the graft quality is excellent. For large volume needs, RIA is definitely the preferred method now.
Okay, what if the bone loss is so massive that just packing in graft isn't enough? You need actual structural support.
Now you're talking structural grafts. For smaller defects, like in the forearm or clavicle, a tricortical piece of iliac crest might work. But for really big defects, especially in the lower extremity, you need something more robust.
And this is where vascularized grafts come in. Why are they better than just putting in a big chunk of dead bone?
Right, because a large, non-vascularized graft, even a big piece of iliac crest, is essentially dead when you put it in. It has to be slowly replaced by the host's body through a process called creeping substitution.
Let's unpack that. Creeping substitution. Sounds slow and unreliable.
It is. It's the body sending in blood vessels and cells to gradually eat away the dead graft bone and lay down new living bone in its place. It takes a very long time, months to years. During that process, the graft is mechanically weak, and often the replacement is incomplete. For a large defect in a weight-bearing bone like the femur or tibia, creeping substitution is just too slow, too weak. The graft might fracture or resorb before it ever fully incorporates. It just doesn't cut it for big structural problems.
So the alternative is
Yeah.
bring the bone with its own blood supply.
Exactly. Vascularized bone grafts, like a free fibula graft. You harvest a segment of the fibula bone along with its feeding artery and draining veins. You transfer it to the defect site. And using microsurgery, you hook up those tiny vessels to recipient vessels near the defect.
So the bone stays alive.
It stays alive. It heals directly to the host bone like a fracture, much faster and more reliably. It doesn't rely on creeping substitution. And because it's living bone, it can actually hypertrophy, get thicker and stronger in response to load over time.
That makes sense. But there's another major technique for massive bone loss or deformity, especially infected non-unions. Ilizarov.
Distraction osteogenesis. Professor Elizarov's work from Siberia. Truly revolutionary stuff.
How does that work? It's not grafting, it's growing bone.
Pretty much. You use a circular external fixator frame, often with tensioned wires and hinges. You perform an osteotomy, a clean bone cut somewhere away from the problem area. Then you attach the frame to the bone segments and very slowly, very precisely pull the segments apart.
How slow?
Usually about 1 millimeter per day, typically split into 4 tiny adjustments, quarter mil each time. This gradual stretch creates tension across the healing tissue in the gap. And Elizarov discovered this amazing biological principle, the tension stress effect. Under this controlled tension, the body lays down new, healthy bone in the gap. You're literally generating new bone length.
And the beauty is you can correct multiple things at once.
That's the power of it. With clever frame design using hinges, angled distractors, differential distraction rates, you can simultaneously correct length discrepancies, angular deformities, rotational problems, all while generating new bone. It's like the ultimate orthopedic multi-tool.
Where do you use it most?
It's invaluable for the really tough situations. Infected non-unions where you have to resect dead bone, leaving a huge gap. Massive bone loss from trauma, severe deformities that need gradual correction. Even for salvaging things like a failed ankle fusion by distracting the joint back open.
But it sounds incredibly demanding.
Yeah.
For the surgeon and the patient.
Immense. The surgeon needs a deep understanding of biomechanics and frame construction. It's complex 3D engineering. And for the patient, it's a huge commitment. Months, sometimes over a year, wearing this bulky frame, constant adjustments, meticulous pin site care to prevent infection, intensive physical therapy. It's a marathon.
And complications, they must be significant.
They are. We can't sugarcoat that. Paley's group, who have huge experience with this, reported pretty sobering numbers. In one series on complex reconstructions, they had 20 major complications needing more surgery while the frame was on, and another 7 major complications after the frame came off.
Wow.
Things like deep pin infections, nerve injuries during distraction, joints getting stiff, the deformity recurring. It's a powerful technique. Nothing else can do what it does in certain situations, but everyone has to go in with eyes wide open about the risks and the long, hard road involved.
Okay, we've covered the bone framework. Now, the wiring. Nerves. Every trauma evaluation starts with neurovascular status, right? But the source warns about being fooled by simple tests.
This is so important, especially early in training. Relying just on gross motor function or basic sensation can lead you astray. Why? Because of substitution patterns and trick movements.
Give us an example.
Okay, classic one. High radial nerve palsy. The wrist and finger extensors are out, but the patient might still get a little bit of wrist extension using the passive tenodesis effect when they flex their fingers. Or they might use intact forearm muscles innervated by median ulnar nerves to kind of flick the wrist back. Looks like a weak extension, but the radial nerve is completely out.
So can you move this? Isn't enough.
Not reliable enough. Another subtle one. High median nerve injury. They lose the opponent's pollicis, the key muscle for true sum opposition, but they might be able to touch their thumb tip to their little finger using their intact ulnar innervated adductor pollicis and flexor pollicis brevis. It's adduction, not true opposition. It looks similar from across the room, but the quality of movement is totally different.
So how do you make sure?
You have to palpate. feel the muscle belly or the tendon you're testing. For the radial nerve, feel the triceps contract. For the ulnar nerve, feel the flexor carpi ulnaris tighten against resistance. Palpation confirms the specific muscle is firing. That's much more accurate than just observing movement.
Got it. Okay, let's talk nerve injury classification. Seddon's system is still the foundation.
Absolutely. Seddon gave us 3 key levels that predict recovery. Neuropraxia is the mildest. It's like a nerve bruise or concussion. The axon itself is intact, just temporarily stunned. Conduction is blocked, but recovery is usually fast and complete once the pressure or bruise resolves.
Like hitting your funny bone, but maybe more severe?
Kind of, yeah. Then there's axonotmesis. Here, the axon itself is broken. You get Wallerian degeneration. The nerve fiber distal to the injury dies off. But the crucial thing is the surrounding connective tissue tube, the endoneurial tube, is still intact.
And that tube is the key.
It's the roadmap for regeneration. After the axon breaks down, the nerve cell body starts sending out sprouts. Because those endoneurial tubes are intact, the sprouts find their way down the original pathway, guided by the Schwann cells inside the tube. So you expect good, functional recovery, though it takes time for the axon to regrow down that tube.
And the worst level?
Neurotmesis. Here, the entire nerve trunk is severed, or so badly crushed that the internal architecture, including those endoneurial tubes, is destroyed. Now the regenerating sprouts have no path to follow. They just grow out haphazardly into the scar tissue, forming a painful ball called a neuroma. Neurotmesis always requires surgical repair for any chance of recovery.
Which brings us to surgery. Timing is always debated, right? Repair it right away or wait?
The classic dilemma, primary versus secondary repair. For a really sharp, clean injury like a knife cut or maybe even an accidental cut during surgery, if there's minimal contamination, doing a primary repair within the first, say, 6 to 8 hours can be ideal. You have healthy nerve ends, minimal retraction.
But most trauma isn't clean.
Exactly. Crush injuries, gunshot wounds, dirty lacerations. The zone of injury is often unclear initially. You don't know how far back the nerve damage extends. In those cases, it's usually better to wait. Delay the repair for maybe 3 to 6 weeks.
Why wait?
It allows the damaged tissue to fully declare itself. The unhealthy nerve ends will demarcate. Then, at the delayed secondary repair, you can confidently trim back the nerve ends until you see healthy, bleeding fascicles, the bundles inside the nerve. This gives you the best chance for a clean repair between healthy tissue ends.
But you can't wait too long, can you? There's a clock ticking, especially for motor nerves.
Critically important, the critical limit of delay. This is nerve-specific and level-specific. The motor end plates, the connections between the nerve and muscle, will permanently atrophy if they don't get reinnervated within a certain time frame.
How long are we talking?
It varies, but for example, the source warns that for a high ulnar nerve lesion up near the elbow, you probably won't get any useful motor recovery in the hand if the repair is delayed more than 9 months from the injury. The muscles will be too far gone by the time the regenerating axon finally reaches them. Sensory recovery lasts longer, but motor recovery has a definite shelf life. It adds urgency to the reconstruction plan.
Okay, let's zoom in on the repair itself, microsurgery. What's the single most important principle?
Tension-free repair. Absolutely paramount. Any tension across the suture line causes ischemia, scarring, fibrosis, and ultimately failure of regeneration. The nerve ends must come together easily without stretching.
And this is where suture choice comes in. The source mentions 9-AJO versus 8-DRO nylon, especially in the hand. Why such a specific detail?
It seems subtle, but it's a clever technical point based on material properties. 9-AJO monofilament nylon is significantly weaker than 8-0. It's known to break reliably at about 5% to 8% strain.
Why is having a suture break a good thing?
Because it acts as a physical safety fuse. If you're trying to pull the nerve ends together and you start putting too much tension on them, the 9-0 suture will snap before you damage the nerve tissue itself or cause pullout. It forces you to achieve a tension-free coaptation. If you use stronger 8-0, you might be able to crank down harder, inducing harmful tension before the suture gives way. So especially for delicate nerves in the hand, the weaker 9-0 enforces that critical tension-free principle.
That's fascinating, like a built-in safety check. And are you stitching the whole nerve sheath or trying to line up the little bundles inside?
Generally, the standard and preferred technique is epidural repair. You carefully align the nerve ends, matching up the pattern of the fascicular groups if possible, and then place fine sutures only in the epineurium, the outermost connective tissue sheath of the nerve, usually 8-0 or 9-0 nylon.
Why not try to stitch the individual fascicles per neural repair? Seems like it might be more accurate.
People have studied that extensively, and the consensus is that perineural repair doesn't reliably produce better functional outcomes. And it has downsides. It's technically much harder, takes longer, introduces more suture material inside the nerve, and risks more scarring and trauma to the delicate fascicles themselves. So epidural repair is generally favored, less trauma, adequate alignment, good results.
Okay, now for the ultimate challenge. Replantation.
Yeah.
A traumatic amputation. Deciding whether to even try to put it back on,
Yeah.
that must be one of the toughest calls in surgery.
It absolutely is. It boils down to one incredibly difficult question. If we replant this, will the patient realistically end up with better function than if we just revise the amputation stump and fit them with a prosthesis? It's a massive judgment call under intense pressure.
What factors weigh into that decision?
Several key things. Patient age, younger patients heal better, regenerate nerves better. Mechanism of injury, a sharp guillotine-type amputation is much better than a crush or avulsion injury, where the tissues are mangled over a longer segment. And critically, the level of injury.
More distal is better.
Much better prognosis for distal injuries. Fingers, the thumb, the wrist, maybe the distal forearm. The closer the injury is to the hand, the shorter the distance the nerves have to regrow, and the better the chance of regaining useful function before the muscles atrophy.
And the proximal ones, above the elbow.
Those have a really guarded prognosis. Amputations through the elbow or proximal forearm. Even if you get the vessels hooked up and the bone fixed, the nerve regeneration distance is huge. It can take years for axons to regrow all the way down to the hand muscles if they ever make it. By then, the muscles are often fibrosed and useless. You can end up with a replanted limb that's heavy, stiff, insensate, functionally worse than a good prosthesis. It's a hard conversation to have with the patient and family.
Let's assume the decision is going. Microvascular anastomosis. Hooking up those tiny vessels under the microscope. What are the key steps?
Right, you need the operating microscope for anything under about 2 millimeters. First step, meticulous preparation of the vessel ends. You have to carefully trim away the adventitia, that loose outer layer of connective tissue back from the edge.
Why is that so important?
Because if you leave ragged adventitia, it can get caught in your sutures and flip into the lumen, the inside of the vessel. That creates a perfect spot for a clot to form. Instant thrombosis, failure of the replant. So meticulous adventitial stripping first.
And then the suturing itself. Tiny thread, tiny needles.
Yeah, we're talking 9-0, 10-0, even 11-0 monofilament nylon suture. For a 1 millimeter artery, you're typically placing only 5 to 8 interrupted stitches. Just enough to approximate the edges neatly, intima to intima. Veins are floppier, thinner walls, so they usually need a few more stitches, maybe 7 to 10, often with slightly larger 8-0 or 9-0 suture. The goal is a watertight seal with absolutely minimal suture material inside the lumen and zero tension. It really is like high-stakes microscopic plumbing.
Okay, beyond just getting blood flow, often these massive injuries need durable tissue coverage, exposed bone, tendons. A simple skin graft won't work there, right?
Correct. A split-thickness skin graft is like laying down sod. It needs healthy, vascularized soil underneath to survive. It won't take directly on bare bone, bare tendon, or cartilage. For those situations, you need a free flap or free tissue transfer.
Meaning you bring in tissue with its own dedicated blood supply.
Exactly. You harvest a block of tissue, could be skin and fat, fasciocutaneous flap, maybe muscle flap, or even bone, osseous flap, along with its feeding artery and draining veins. You transfer this whole unit to the defect, and then you perform microvascular anastomosis, connecting the flaps vessels to suitable recipient vessels near the defect. This brings in healthy, vascularized tissue to cover the exposed structures, allowing healing and preventing infection.
Can you give some examples of common flaps used in reconstruction? What are their pros and cons?
Sure. A well-known one for hand or foot coverage is the dorsalis pedis flap. It's taken from the top of the foot, advantage. It's relatively thin, and crucially, you can include sensory nerves, branches of the peroneal nerve, with it. So if you connect those nerves in the flap to sensory nerves in the hand, you can potentially restore feeling to the reconstructed area. Big plus.
The downside.
The donor site. Taking that flap leaves a significant defect on the top of the foot that usually needs a skin graft itself. Can lead to pain, stiffness, poor cosmetic appearance of the foot. Always a trade-off.
What about the lateral arm flap?
Another useful fasciocutaneous flap comes from the outer aspect of the upper arm. It's also thin, contours well, and it has a reliable sensory nerve, posterior cutaneous nerve of the arm, for potential reinnervation. The main challenge with the lateral arm flap is often its vascular pedicle. The artery and vein supplying it can be quite short, maybe only 2 to 6 centimeters long.
Which makes the hookup tricky.
It can. If the recipient vessels are far from the edge of the defect, that short pedicle might not reach. You might need to use vein grafts to bridge the gap, which adds complexity and another potential failure point.
Okay, those are mostly for coverage. What if you need to replace lost muscle function?
Then you need a functioning free muscle transfer. The classic workhorse for this is the gracilis muscle.
From the inner thigh.
Yep. It's relatively small, has a long strap-like shape, and a reliable dominant vascular pedicle and motor nerve. You harvest the entire muscle as a neuromuscular unit, transfer it to, say, the forearm to restore finger flexion, or to the upper arm to restore elbow flexion after brachial plexus injury. You hook up its artery and vein, and crucially, you suture its motor nerve to a donor motor nerve near the defect, maybe an intercostal nerve, or a branch of the spinal accessory nerve. If the nerve regenerates successfully, the transferred muscle will contract and provide active function. It's not just filling a hole, it's restoring movement.
Incredible. Finally, let's loop back to bone grafts for huge defects, but the vascularized kind. You mentioned the fibula. Why is adding that microvascular step so important for bone?
It comes back to beating creeping substitution. Vascularized bone grafts, the fibula being the prime example because it gives you a long, straight, strong piece of cortical bone, up to 26 centimeters sometimes, or sometimes a vascularized piece of iliac crest. These grafts are transferred alive.
With their own blood supply intact via microsurgery.
Exactly. So they don't die and wait for the host to slowly replace them. They integrate directly and quickly into the host bone at both ends, healing like a fracture. They maintain their mechanical strength throughout the healing process.
And they can get stronger over time.
Yes. Because they are living bone, they respond to Wolff's Law. They sense the mechanical load and can hypertrophy remodel and thicken to meet the demands placed on them. A non-vascularized graft just slowly resorbs and weakens over time, often failing under load. For bridging a massive gap in a femur or tibia, a vascularized fibula graft is often the only reliable way to achieve solid, durable, long-term reconstruction.
Of course, taking out the fibula has consequences too.
Absolutely. You have to weigh the benefits against the donor site, morbidity, potential ankle instability, maybe some foot symptoms. But in the context of salvaging a limb with massive bone loss, it's often a very worthwhile trade-off. #tag outro.
Wow. Okay, so this deep dive really covered the map, didn't it? We went from, large-scale mechanical problems, cranking open a calcaneus with a distractor, planning precise bone cuts, real structural engineering.
Yeah, big picture mechanics. And then we zoomed right down to the tiniest details where success or failure hangs by a literal thread.
Like needing 7 perfect stitches in a 1 millimeter artery. Or choosing 9 or nylon because it's weak enough to prevent you from over-tightening a nerve repair.
It really underscores the multiple hats the reconstructive orthopod has to wear, doesn't it? You need to be a biomechanical engineer thinking about load sharing and frame stability for distraction osteogenesis. Then a microvascular plumber connecting vessels barely visible to the eye for a replant or free flap.
And a neurobiologist almost, predicting nerve recovery timelines and understanding regeneration limits.
It's this constant back and forth. How do you solve this massive macroscopic failure, the mangled limb, the bone gap, using techniques that demand absolute microscopic perfection? You're applying huge forces with an external fixator 1 minute, and the next you're manipulating tissues under 20x magnification.
So maybe the final thought for our listener is this. As orthopedic reconstruction pushes boundaries, blending macro repair with micro repair, what does that future look like? Is the ultimate challenge less about inventing new implants and more about perfecting this interface between large-scale biological failure and the absolute smallest, most meticulous surgical intervention? It's not just about strength anymore. It's about incredible, almost inhuman finesse.
That's a great point. Matching the scale of the problem with the precision of the solution, that's the ongoing challenge and really the art of what we do.